Thank you very much for inviting me. And I'll figure out how these buttons work. There we go. And greetings from Canada. This is what we all look at, think of when we look at Canada, and it really is like this in some places. This is probably a little bit more realistic. This is the Montreal forecast for the next few days. There may be some little icons on there you don't recognize. They're snow. There's also one that looks like rain when it's a -1, which you can imagine is a lovely time. So I'm even more delighted to be here because of this slide. So I'm a clinician educator, and a lot of what I say will be said from the perspective of education. I've also had the privilege of working with Dick and Sylvia Cruz and others at McGill who have been doing a lot of work on professionalism, defining it, teaching it, talking about how to teach and how to assess it. And I've also had the opportunity to work with colleagues at the Royal College and in other places on a competency-based education group. So my perspectives are going to be coming from those directions. I'll go back a bit. So we all know who that was, right? So I'm hoping that we can look at some definitions. We've had a lot of them, so I'll be flying through some of them, but discuss a little bit about the links between competence and professionalism, factors contributing to a competent professional, explaining how we assess this, but also looking at a little bit to the future and imagining what the competent professional of the future will be like. So we know who this is, right? Anybody who doesn't? All right, okay. So Dr. House makes wonderful diagnoses. I don't quite know how he gets there sometimes, but he does, and he might be considered professional. We don't necessarily consider him competent in many ways and professional in other ways. So why this renewed interest on professionalism? I think we've heard it from our last speakers about the decline in the profession's relationship with society. Public lapses of professionalism, I mean our lapses of professionalism that have become public. And Maxine Papadakis and others' work showing that those who demonstrate poor professionalism during medical school or residency are often those who demonstrate unprofessional behavior in practice. That link has been shown. The second thing is, on a more positive note, there's been growing interest in professionalism from within the profession. We've seen our consensus statement here, the Charter on Professionalism, definitions. There are standards of accreditation for almost all our constituencies. And we also have an increasing body of knowledge on how to teach effectively and how to assess effectively. It's not perfect, but it's getting there. We've also had increasing attention paid to competence, its relation to society and societal needs to make what we're competent in relevant. The idea that a graduate needs to be competent in all domains. I think it came up in one of the questions. Somebody was considered competent but was not a good team player. I would say that person was not competent because he wasn't competent in teamwork. And transparent standards. We have competency frameworks. We have people looking at those competency frameworks from the perspective of flexibility and efficiency. Excuse me, and I haven't had any wine. Flexibility and efficiency. In other words, can we make our education more efficient by using this approach to competencies? And there was a recent consensus on the concepts of competence and competency, which was published in Medical Teacher last year. So one of the things that Dick Cruz taught me was it's always a good idea to start off with some definitions so everyone is on the same wavelength. So I'll go through two definitions. You'll recognize one. This is the definition of profession, which I will not repeat because it was just read, published in Teaching and Learning in Medicine. The reason for this being published was so that medical educators would have something to hold on to as they started to develop their teaching and assessment methods. But within this, I think you'll see two things that we've alluded to. One, I think you can see it, the blue text, which really talks about the attributes and the characteristics of the professional, the commitment to competence, morality, altruism, etc. The other part of this is the idea of the social contract, the link between the profession and society, and what goes into that. And my colleagues yesterday actually asked me to include this diagram to try and make that clear. We have a physician and we have a patient, and there are some reciprocal expectations and obligations between that physician and patient. We also have the collection of physicians, call it the profession, and the collection of patients and others, call that society. And there are the reciprocal expectations and obligations between those two groups, and that's the social contract in medicine. Not a written contract, but a conceptual contract, which basically underlies the concept of professionalism. So we've talked a little bit about what goes into one side of this, but I think we've got to remember that there are two sides. What we would like as a profession is some autonomy, to be able to regulate ourselves and decide who comes in, who doesn't, as was mentioned before. Trust, a role in public policy, rewards, not only financial, but other rewards, stature, things like that. What do our patients and society want? They want us to be competent in all the roles and competencies. They would like altruistic service. They would like us to have those characteristics that were mentioned, the morality, integrity, the accountability and honesty. They would like us to respect the patient autonomy and to promote the public good. These are some of them, not all of the things that go into the social contract. And this, I think, became clear when you looked at that tri-college consensus that was shown just before the break. Professional competence includes a broad array of competencies beyond medical expert, which you may have noticed Ken calling the intrinsic roles, those things that we don't like calling the non-medical expert roles because it kind of devalues them. We call them the intrinsic roles in Canada. And part of professional competence is demonstrated continuing professional development and lifelong learning. So those are some of the concepts that go into professionalism. What about competent? If I asked you to think about a word or two or three or a phrase that described competent, what would go through your head? We have people here who are regulators, teachers, all sorts of people. I'm not going to ask you, but just think about it now. This is a definition that was actually used for a fair bit of time in the early 2000s by Ron Epstein. The habitual and judicious use of communication, knowledge, technical skill, reasoning, emotions, values, and reflection in daily practice for the benefit of the individuals and the community being served. So here we see two things. We see a number of competencies, communication skills, a number of attributes, like values, and the idea that what we do is for the benefit of the patient and society, which is part of the social contract. Our competency-based education group rewrote it slightly, and we defined it as an array of abilities, again, knowledge, skills, and attitudes, across multiple domains of performance and in a context. That's something that came up in the panel discussion earlier on. It requires qualifiers to define what the ability is, the context, and the level or stage of training, the milestone. That's important. We don't expect a junior doctor to be as competent as a consultant, but we expect them to have certain parts of the competency. It's multidimensional and put together like building blocks, and it's dynamic in that it changes over time with experience and with a certain setting. Couple of other definitions just to help us get on the same mindset. A competency is an observable ability. Observable, therefore it can be measured. Integrating multiple components of knowledge, skills, and attitudes and values. So a competency is fairly big. It's not necessarily a bit of knowledge or a specific skill. It might be the competency of doing a surgical procedure, which will involve the technical skill, the knowledge of anatomy, and some communication skills, for instance, and a certain attitude or problem-solving skill. The competencies are assembled like building blocks so that people can progress over time and can progress towards being competent, having the minimum required abilities at a certain stage in a certain context. So does that make sense? Just so we're on the same page in terms of definitions. So I think you can see that there are already some links between professionalism and competence. Every competency framework I've seen here in Australia and Canada, the good doctor in the UK, the Scottish doctor, the ones in Japan, all include professional as a role or professionalism as a competency in their frameworks. Professional or professionalism definitions include concepts of competency, of maintaining competency, of being competent and having expertise, and having it across a multiple broad series of roles. And of course, the social contract talks about maintaining, acquiring and maintaining competence, and self-regulation in part has to do with maintaining competence. In fact, a colleague of mine said the other day, you can't be a professional without being competent. I would say, maybe the other isn't true. You could be competent and not be professional. Look at Dr. House. So let's move on, if we have some definitions, to what makes a competent professional. This is our CanMed's Daisy. I gather the Australian surgeons have added a number of petals to the flower, but most of them are still pretty similar. And the conceptual point here is that although medical expertise is at the center, all of these overlap, and whatever conceptual concept map you use or visual model, most of the competencies overlap in some way and are linked in some way. They're not, the trouble is they're often taught separately, and then one is expected to integrate them in daily practice, and that can become a challenge. So what makes a competent professional? I'll divide it into three things. One are the attributes and characteristics that we were talking about earlier. The second is education. And the third is what happens in practice. And I'll address each of these a little bit. Attributes of the professional. This is a diagram that we use at McGill. Every single medical student sees this on day one of medical school and throughout medical school at various stages. Our residents see it during their sessions on professionalism, and our faculty who are teaching our residents see this diagram during their faculty development sessions. This is a definition and some concepts which have been agreed upon across the continuum, across the institution that gets taught. And you'll see here a number of attributes and characteristics of a professional. And I think you could probably imagine putting a circle off to the right, to your right of this, and putting some things in about law or engineering or whatever, and that would become the attributes of a lawyer or an engineer or another professional. What we've done is said, here are some specific characteristics or attributes that belong to the physician. So the sort of, we call it the healer, not meaning that in a very general way. So those issues that we talked about earlier of caring, compassion, respect for the patient go into that category. But both the healer and the professional part of our beings, all of which make a physician or a surgeon, are things like competence, commitment, altruism, morality, trustworthiness. And then those specifically professional roles or characteristics are things like self-regulation, teamwork, and responsibility to society. So this is the conceptual way that we introduce professionalism to our learners at all levels at McGill. These could be considered the attributes and characteristics of a physician. I'll talk a little bit later about what we think about and what the evidence is to whether professionals or physicians are born or made when it comes to these attributes. So what about educating us? What do we really have to think about? And I'll spend a little bit of time on this. We're clearly going to want to educate for expertise, what it is that we need to know. We need to impart that specialized, complex knowledge to plan and make expert judgments. It's not simple stuff. We need skills. Skills in the techniques to find solutions, intervene effectively. This just does not mean technical hands-on skills. It can mean communication skills, leadership skills, a skill in advocacy, for instance. And we need character. We need to educate people in terms of character, to strengthen the attributes they have, and perhaps to provide or encourage them to demonstrate behaviors in characteristics that they may not have when they come in to their training. So if we look at the first two of those, if we look at expertise and skills, and go back to thinking about competence, I think you can see that for each domain of competence, there could be a progression from novice to mastery. I was interested in seeing the document from the College of Surgeons, which describes in great detail what does a novice, a mid-level person, an expert, someone who's very proficient, have for each of their 9 domains. The goal of education is to make sure that a physician has the level, the competence that's necessary for optimal practice in each of those domains. So this implies that you'll have a greater or lesser ability depending on the context. Alongside this is the need to develop a professional identity. And I think at McGill we're moving towards thinking about this area as well as thinking about just teaching and assessing professionalism, recognizing that it really is an identity that we're not trying to change somebody's underlying identity, but add to it some concepts that we consider, some behaviors that we consider very professional. I think the first quote that our first speaker gave from William Osler spoke to this very well, about being a professional. Now, to make sure that individuals can develop a professional identity, we probably need some different teaching and learning methods than we've actually used in the past. We probably do need to convey a certain amount of core content, which can be done in the traditional teaching ways, lectures, small groups, working with vignettes, whatever. But the idea of using guided reflection, role modeling, experiential learning, and probably the judicious application of appropriate amount of stress, that's been shown to actually, it sounds crazy, but it's been shown to actually help form identity. That doesn't mean keeping people up for 48 or 72 hours and yelling at them, but there's a certain amount of stress. Being put out of your comfort level of knowledge is a certain amount of stress that will help you learn, for instance. And this happens across a continuum. It doesn't happen in a course on professional identity, obviously. It happens from the time people reach medical school well into practice. So if we look at how original or traditional medical education curricula were developed, and I think this would sort of describe the way that I went through medical school and residency. It's dependent on time on a rotation. I did 2 months of medicine and 1 month of surgery, etc. And the structure was those rotations that I went through. And the rotations were really the unit of curriculum. It was medicine. I didn't go there to learn communication skills or advocacy. It was medicine, which meant that it was quite knowledge-based. And my goal was to pass that rotation. And I was assessed to see if I was ready to go to my final Royal College exam or my final medical school exam with in-training assessments, final in-training assessments, oral exams and the likes, and written exams. And my program director and their administrators were really focused on getting us through the rotations and making sure everyone had an appropriate exposure. My teachers supervised and taught me, more or less, and my job was really a job to provide some service on the rotation, and if I was lucky, learn at the same time, go to lectures when I could, and study for exams. And this is, I think, the way that medical school for the last, and residency, up until the last 10 years at least, worked. And some people have called this the tea bag or the tea steeping model. You've probably heard this. This is, you put someone in an environment, you steep them in that environment for a period of time, and they come out done and ready. Obviously, there are some problems with this. So, and I know competency-based education has been a hot issue here. Here are a couple of definitions: an approach to preparing physicians for practice that's oriented to the graduate outcome abilities and organized around competencies, and these competencies are derived from societal and patient needs. So basically, you start with the end in mind. The other thing, the other definition has been an outcomes-based approach to not just the design, but the implementation, assessment, and evaluation of medical education programs using that framework of competencies. So if we take that and try and put it into a design for a residency curriculum, what will you have? This will be, and imagine yourself being a residency or junior doctor program director for this. You're going to have a time-free system where the goal is really progression of competency. Once an individual junior doctor or medical student achieves that competency, they're gone, they're out of there. It is structured in that it's a learner-centered curriculum. It's time independent. If a learner's having trouble learning something, they'll stay for a while. If they're good, they're gone. The rotations are really not, they're secondary to learning. The role of in-training assessment is actually to document whether you're achieving the milestones on the way to achieving competency. And the final assessment is to make sure you have finally reached that minimum competency standard. The assessment tools, by their nature, have to be very different. Portfolios, for instance, are used. And the focus is, can these people achieve competency? Teacher roles are different in that the teachers must spend much more time in direct observation, observing to see whether competency has been achieved. And the ownership of learning is with the learner. And they are, in a sense, plotting a course for progression through the acquisition of competencies with the help of their teachers. So now imagine yourself, we've got a new crop of junior doctors coming in, you've got a list of competencies, and it's chaos, right? So I think most of us would find it very difficult to have a pure competency-based model. There are a few that are being tried. There's the orthopedic surgery program in Toronto, where there are a few very well selected to be the top trainees, residents in the program. And interestingly, because somebody's likely to ask, it doesn't seem to be shortening the length of training. I think there's also one of the junior doctor programs here in Australia in psychiatry is playing with a relatively time-free curriculum, a competency-based curriculum. So I propose that there's something in the middle so we don't all go crazy trying to develop a pure competency-based program. One where there is a progression of competence, but rotations are really only one learning method. There's a flexible curriculum that helps people learn competencies in different ways that either complement or supplement their rotations. The rotations are really that resource for acquiring competencies, And the other difference, I think, is that the acquisition of competencies probably should be done over a course of time. For some of the competencies, I'll go back to thinking about professionalism. I don't think we can say, let's have a professionalism rotation, or we're going to develop into a professional overnight. So there may be a time factor that is actually necessary for a certain number of the complex competencies that demand a lot of behaviors and attitudes and values. We may need some time for that to develop. So this is sort of a hybrid model. It focuses on curricular outcomes. It emphasizes abilities or competencies as organizing frameworks, but there's a logical progression with a de-emphasis, not a removal, of time-based training. It certainly allows greater flexibility for learners who are doing well, greater accountability in terms of making sure that what you're learning is appropriate for where you're going to practice, for instance. Promotes learner-centeredness, which will be really necessary when that individual is out in practice and has to continue learning. And the standards are very visible. So obviously there's been some criticisms of competency-based education, some resistance to the idea of time-free curricula. It certainly would cause chaos, the way we think about it now. There's also been questions about how somebody could be assessed. The comment about we're just aiming for a minimal level of competence, we're not aiming for expertise. We have to be sure that we're not reducing our competencies to too much, that we remain broad with our competencies. And we also have to think about how we acquire things like professionalism. So it's not a perfect fit. It's just something that I think we need to think about these days. If we move into practice and think about the competent professional in practice, they would probably continue with their competency-based education. They would be self-directed, flexible, adaptable to the practice they were in, probably more reflective. They would have learned how to do that during their training so that they could acquire the lifelong the competencies they needed, and also acquire the competencies for lifelong learning, which was mentioned to many of you who were here talking about the learning management system. It's a whole set of competencies to learn. I'm not going to talk much about assessing the competent professional, but somebody asked me to just say a few words. The competent professional in practice will need ongoing assessment. This is Miller's triangle. I'm sure many of you are familiar with it. And what we're really trying to do with the individual in practice is assess what they do in their work, driven by their needs and linked with their learning. So for those of you who are regulators or college people, I think if you think about assessment as of someone in practice as something that is done in the workplace for the majority of people, it's continuative, it's fed back to the individual so they can learn from it. We can use some old assessment methods, but we need to use them quite effectively. And we can develop new approaches. I'm not sure whether I'd call a 360 or a multi-source feedback new or old, but it's things like that that are often used. One of the basic principles, or some of the basic principles, is there are multiple observers, multiple methods, and individuals are measured multiple times. If we look at assessment systems, they must be comprehensive, they must be fair, defensible, certainly I think our regulators would say that, practice-based, and relevant to what the individual is doing. So that's all I'm going to say about assessment as part of the competent professional in practice, except that it must be done. Going back to professionalism, it is the professional thing to do. It's linked with self-regulation and assured competence. So if we look at the generation before me, I hear stories about individuals who studied all the way through medical school, passed exams, the exams were knowledge-based. They went into a residency program. If it was a surgical residency, they lived in the hospital for X number of years. Their chief surgeon told them whether they could or couldn't get married. They went into practice where they were done. They did their exam, they were done. They didn't have to do any more learning necessarily. They had high stature. And the doctor-patient relationship was probably a little unequal. So that is the way a competent professional was sort of looked at some years ago. If you look at the individual today, they had the kind of training that I've described I had. Usually it's still time-based. It's tested by knowledge tests. When I came, for the first 2/3 of my practice, continuing education, continuing professional development was not mandatory, and what I went to usually was lecture-based and knowledge-based, and certainly didn't address some of the needs that I myself felt I had in terms of some of the other intrinsic CanMeds roles. We didn't really talk about quality or safety or things like that, but I think I was still considered a competent professional. So what we'd like to do now is really look to the future. And I've thought about what it is that's driving change. I'm going to fly through these because we've actually heard about some of these in the last discussions. The way I've tried to categorize them is I've looked at it as drivers from 5 different areas: society, the healthcare system, medicine, learning, and the profession itself. We've already talked about differences in societal expectations, changing doctor-patient relationships, professionalism, something that was addressed today, that's a hot issue in Australia, communication, compassion, that's what our patients want us to have. The idea that society is much more diverse, and in fact our incoming trainees are much more diverse. And we have to deal with this diversity and have some competence in it. And we've already talked about threats to self-regulation and how to address it. Our systems are changing. Things like patient safety, quality, workforce issues are hot issues around the world. The ones with asterisks are ones that I know are relatively hot issues here. Access to resources. People are practicing in different settings. Most of these settings are in teams, and efficiency is a big word. Medicine itself, I'm not going to go into it. We know there's a knowledge explosion, technology advances, evidence-based medicine, and the emphasis on prevention and on population health. From my perspective as an educator, there's all this information, but it's also way more available, and the speed of acquisition or exchange of information is huge. Training settings are different. For better or for worse, there is a student-centeredness to it. And there are different and wonderful learning methods and formats that can be used, such as simulation. And there is this trend to, and sometimes a push to, competency-based education. If we look within the profession itself, there's changing roles. There's things like physician health, which I neglected to mention, but is one of the things that the Royal College has added to our definition of professionalism, which looks very much like that definition I showed you earlier. There are generational issues. This is something that I believe was addressed earlier. Gen X, Gen Y, whatever. Each generation with a different relationship with authority, career expectations, learning styles, and issues to do with work-life balance. Now, my clock went off, but it looked like 2 minutes.
You seem to be doing just fine. So
okay, sure. I'm almost finished. Okay. Very distracting, that. So here are some of the issues other than generational issues. Workloads, duty hours are things that are coming up within the profession. There's also been some comment, and I think it was brought up earlier, about the expression of attributes of professionalism. Is altruism dead? From our work at McGill, and certainly from looking at our students and residents, the main issues come up around the attributes of altruism and commitment. And our observations are that It's still there. It's just expressed slightly differently. And I read a quotation which basically said, well, in the old days, you know, they weren't like us, and they didn't work hard, and all the kinds of things that you hear people saying. And then I looked at the date of the quotation, and it was 1895. So I suspect that this issue about generational change has been going on for a while. So let's look at, we've got all these drivers. Let's look at and imagine what someone will look like as a competent professional 20 years from now or 10 years from now, and I hope it's sooner than 20. First is that competence will be assured because they will have gone through some sort of education and into practice such that all the intrinsic roles, competencies, have been addressed and are maintained. At the same time, they will be flexible and responsive to change. We've got to recognize that change is happening, and somebody who goes out into practice is not going to be fit for practice from the competency point of view several years down the line. They'll have to be able to self-address, to address their own needs in practice. They'll have to have those lifelong learning skills I addressed earlier on, skilled at information retrieval, the application of what they find, and learning around the competencies they need to enhance performance in their practice. The competent professional of the future might well have been selected for the desired characteristics. It was one of the questions earlier on. I think there is some evidence that one can try using multiple mini-interviews or other formats like that to select for the characteristics that you'd like to try and develop in your students or in your residents. We do not yet have the evidence whether that is a successful way of doing it. The MMI project started 3 or 4 years ago, so we don't know whether that's going to make a difference in people 5 or 10 years down the line. And as I mentioned, there will be individuals with a different expression of professionalism attributes. They'll work in different places. They'll do more ongoing care. They'll take care of more chronic illnesses. They'll be working mainly outside of tertiary institutions, and they'll be working in systems that are structured for physician health, structured such as having decreased hours of work. And our concepts of professionalism will have to change to be built into that. So if somebody doesn't stay around to learn, if there's another way of learning what it is to be taught, if there's an asynchronous online module, and they'll learn that way, that's okay. That's still a commitment to learning. They'll have a different emphasis than the emphasis that I had when I went through my training. Patient safety, population versus individual medicine, prevention, being culturally competent. We're all living in a diverse society. Being able to better manage resources, having a respect for patient autonomy and having a different relationship with the patient. Learning and working on teams and addressing physician health are some of the things that come to mind. So in closing, I think I've talked a little bit about some evolving concepts of physician competence from the time of apprenticeships and guilds and surgical residents who couldn't get married to moving into institutions like universities, but where there were still tests that were primarily knowledge tests, to thinking about tests and time, and eventually the multi-dimensional abilities or competencies needed for practice. So how we address these challenges and changes will actually impact on our practice as educators and regulators and as clinicians and teachers. What do we have to do? I think we have to be responsive to change. We have to be proactive and complete the loop that Sir Liam talked about. We have to look at education, particularly for things like professionalism, as something that goes across the transition of education and needs some common definitions and approaches from the beginning of medical school well into practice. We have to pay attention particularly to the transitions between those sections of our educational systems. We may want to consider selecting students and residents for certain attributes. We need to recognize that there are broad competency areas beyond medical expert, and including professionalism that need to be taught and learned. And there are new models of education like competency-based education and new educational strategies like explicit role modeling and reflection that can be used to teach some of these competencies. We need to develop lifelong learning skills. And we need to assess these competencies, the competencies needed in practice. And I think to do that, to address one of the other questions that came up, we can't assess attitudes, and we can't assess values directly. We can certainly assess behaviors which we feel reflect those attitudes and values. And we have to recognize that part of the social contract, that social accountability role, and give some feedback to society so they recognize that we're working on our professionalism, because our primary goal is excellence in care for the individual and for societies. So I think to do that, we have to just jump right in and do it. I'll stop there. Thank you.